طيب بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. Initially, I would like to welcome all of you. And as usual, I'm looking to the number of attendees until now. The one who registers actually was almost 7,000, and then now who's attending almost we are reaching to 3.7 thousand. And I wish all of you enjoy the talks and the activities of the Saudi Society of Nephrology and Transplantations. So today we have another interesting topic to be discussed, and this event is have been sponsored by Payer's company, which would like to thank them. Without them and their support, this event wouldn't be happened. And specifically also would like to thank Dr. Khalid Arif for wonderful collaborations with them. As usual, the Saudi Society of Nephrology and Transplantation thanks all the companies who's collaborating with us and sponsoring the pure educational events, pure education and scientific events. So I would like to introduce initially our panelists or moderators, Dr. Khalid Al-Ma'atham. He's one of the senior nephrologists at King Fahd Medical City. So the mic is with you, Dr. Khalid.
Assalamu alaikum and good evening, everyone. Thank you, Dr. Khalid, for your kind introduction. It's my pleasure to be here tonight with you, and thank for the Saudi Society of Nephrology for the invitation. It's my pleasure to introduce our speaker tonight, Dr. Mohanad Al-Maimani. Dr. Mohanad graduated from King Abdulaziz University. Then he did his residency training for internal medicine and general nephrology at University of Toronto. Then he did his subspecialty in glomerulonephritis at University of Toronto also. Also, he has a research fellowship from Washington University or George Washington University fellowship. Dr. Mohanad, he got his degree on 2022, and since then he's working as assistant professor at University of Jeddah, and he is internal medicine and nephrology consultant. Tonight, Dr. Mohanad will talk about non-steroidal mineralocorticoid receptor antagonists in diabetic kidney disease. Before we start, just housekeeping issue that please, all the questions will be answered at the end of the presentation, and keep all the questions in the Q&A panel so we can take them one by one. With that, I would like to hand the mic to Dr. Mohanad. So please, Dr. Mohanad.
Thank you, Dr. Khalid, and I'd like to extend my thanks to the Saudi Society for this kind invitation. Tonight, inshallah, I'll be talking about the non-steroidal mineralocorticoid receptor antagonist, or the NSMRA, in diabetic kidney disease. So first of all, we all know that development of diabetic kidney disease is a serious matter. So chronic kidney disease is common in diabetes. It's prevalent in both diabetes types. It reaches up to 40% of type 2 diabetes. We know that diabetes is the leading cause of CKD and end-stage kidney disease worldwide. We have a local study done here in Saudi, in a multi-centric study actually, illustrating that the diabetic nephropathy frequency increased about 10 times over the past 2 decades in a large number of renal biopsy specimens. We all know that the CKD is a risk factor for cardiovascular disease, and it amplifies the risk of cardiovascular disease. We know that the stages of diabetic kidney disease ranges from very mild, stage 1, which start with early hyperfiltration, going through structural and morphological changes without any clinical signs, extending to microalbuminuria, which we call these days moderately increased macroalbuminuria or macroalbuminuria within the end-stage kidney disease. So we know that the higher the albuminuria, the worse the outcome. So severe albuminuria, we know that it increases the annual risk of mortality by about 4.6%, and the risk of progression to end-stage kidney disease by 2.3%. So since the disease is quite serious, we have to screen for it, especially that the early stages are asymptomatic. And this is across multiple guidelines, such as ADA or National Kidney Foundation. And we have to do an appropriate screen. And what I mean by that is to do both the serum creatinine to get the GFR and the urine microalbumin to creatinine ratio. We know that in type 1, you can do that after 5 years of the diagnosis. However, in type 2, you have to do it once the patient is newly diagnosed. So patients with urine ACR of more than 30 milligram per gram, which is equivalent 30 milligram per day, and or eGFR of less than 60 should be monitored at least twice a year to guide their therapy. So we ask ourselves a question here: is clinical practice would be matching the universal screening guidelines? Well, I have an example from a study that was done in Canada, retrospective over a period of 5 years. So we have a good duration of follow-up and a large number of patients, close to 2,400, that are newly diagnosed with type 2 diabetes. So the results showed over half of those patients were screened with eGFR alone, 7% only screened with urine ACR alone, 24% had neither screen with urine ACR nor eGFR, and only 6% had both urine ACR and eGFR completed within the first year after diagnosis. So this is a universal issue. It's not only localized to a certain country or place. So eGFR tells you half the story. So we have to do both eGFR and urine ACR. So that gets me to talk about the strategies to prevent progression of diabetic kidney disease, starting with healthy lifestyle modifications. This is the base to start from in every single patient by recommending weight loss, moderate intensity exercise, 150 minutes per week, healthy diet, smoking cessation to be recommended, glycemic control of hemoglobin A1C less than 7%, and take in consideration to individualize your hemoglobin A1C targets based on the patient age and comorbidities. Blood pressure control to be less than 130 over 80 millimeter mercury, as we all know, to target the glomerular hemodynamics / metabolic pathways. And here I'm talking about that our knowledge of the DKD or diabetic kidney disease driving factors is an important fact here, so we know what we would be targeting. So here I'm talking about the RAS blockers, SGLT2 inhibitors, and GLP-1 receptor agonists. In addition to the novel therapies, such as non-steroidal MRAs that would act on the anti-inflammatory pathways. So very briefly, the hemodynamics of the glomerulus, our goal here is to reduce the intraglomerular pressure, either by...
Dr. Mohammed,
Yes?
kindly, can you switch off your the video, the camera, so that to have better internet connection?
Sure.
If you, yeah, just to switch off the camera only. Excellent. Go ahead.
Okay. So by vasodilating the efferent arteriole or vasoconstricting the afferent arteriole, and the end result would be decreasing the filtration or the hyperfiltration that happens quite early in the diabetic kidney disease. So you would imagine if the RAS blocker would do good and the SGLT2 inhibitor would do that as well, combining both would get a better result, but with cautious introduction of either medication sequentially. So despite the good result that would be exerted by the RAS blockers, we have two famous trials, the RENAL and the IDNT. RENAL had a risk reduction of 16% of the hard renal endpoints, such as doubling of serum creatinine, end-stage kidney disease, or death. And IDNT had a risk reduction of 20%. both of them were significant. However, the absolute residual risk in both trials would approximate about 40%, which is not an easy number, which indicate the need for more therapies to prevent further progression of the DKD. So this was in 2001. You would imagine after that, for a number of years, multiple experimental therapies failed to provide cardiorenal protective effect until we got, I'd say, in 2019, the beginning of the first kidney outcome trial from the SGLT2 inhibitor group. It was the Credence trial with a hazard ratio of 0.7 from the primary outcome, which is end-stage kidney disease, doubling of serum creatinine, renal or cardiovascular death. So it was a cardiorenal primary outcome. So hazard ratio of 0.7 would translate to a risk reduction of about 30%. This extended to DAPA-CKD, which was targeting also the non-diabetic CKD group as well, with a very good risk reduction that is about 39%. And this was extended to the IMPA kidney trial that was published in 2022 with a GFR of at least 20, with a risk reduction of about 28%. So great results, very good outcomes, very promising therapy to be added to the group of preventive strategies. But again, we face the issue of residual risk. In Credence and DAPA-CKD, for example, that is about 11+% in either of these trials. So again, I'd go back to my point of the drivers of DKD progression. We have talked about the metabolic pathways, the hemodynamic pathways, but what about the residual inflammation? And by the way, when I say residual inflammation, we could talk about that by seeing the amount of albuminuria, which is, by the way, a very important marker of inflammation in the renal tissue. So we all know the MR overactivation has been linked to cardiovascular disease and kidney disease through inflammation and fibrosis. We know that the mineralocorticoid receptor get faced with or attacked by the non-steroidal or steroidal mineralocorticoid antagonist. We know the steroidal MRAs since the 1960s, spironolactone, which was followed by eplerenone after that, which is very well proven in treating heart failure and resistant hypertension as a fourth line. In 2012, this was followed by the non-steroidal group, which is actually quite different from the steroidal group. And even this group, the non-steroidal, there are multiple of them and they are different amongst themselves. So the steroidal group, as I mentioned, such as spironolactone and eplerenone, used in heart failure, resistant hypertension, we acknowledge that there is some evidence of albuminuria reduction. However, there is no solid effect on slowing the DKD progression. We know that there is a significant side effect profile, including hyperkalemia and acute kidney injury, in addition to hormonal side effects, such as gynecomastia and erectile dysfunction. So the physiochemical properties of either of these agents is quite different. So the finerenone is bulky in comparison to the other ones, which is flat. The importance of this bulkiness that it induces conformational change, and it gets the finerenone to be very potent to the mineralocorticoid receptor, about 500-fold of being potent in comparison to the other agents. Spironolactone only 3-folds, and the eplerenone only 22-folds. The selectivity of finerenone is quite high, and this is the reason for less side effects, I should say, such as like sexual side effects. The half-life is only 2 to 3 hours, and you could ask yourself why it's given once a day. But according to the literature that I went through, that it's not about the duration or how long the medication lasts. It's how strong the medication would be linked to the receptor because of its bulkiness and because of its conformational change that would induce multiple genes and multiple sequence of events after that that last quite long. So finerenone, the journey starts from preclinical models that showed some benefit from cardiorenal aspect that I won't go through. Then the phase 2 trials, which is the ARTS program, which is I'll mention very briefly as well. Then in details, the phase 3 trials, which is Fidelio, Figuro, and Fidelity, which is collectively known as the finerenone program. So phase 2 trials, starting with the ARTS, which is a head-to-head comparison between finerenone and spironolactone that showed, I'd say as a takeaway point, less hyperkalemia in the finerenone group and equi-efficient cardiac biomarkers comparing with the spironolactone. So efficacy was the same, but safety was better with finerenone. Moving to the ARTS heart failure, it tests the more than 30% reduction in the BNP. It was comparing finerenone and eplerenone here, and there was no difference actually between both. And the most important one that I want to mention is the ARTS diabetic nephropathy, which was testing finerenone versus placebo over a period of 90 days in CKD with type 2 diabetes, who are receiving the maximum RAS blockade in a urine ACR that is at least 30 and eGFR that is at least 30 as well. And there was a reduction in the urine ACR that is dose dependent in this trial with very well tolerated hyperkalemia that was noticed here as well. So the good results of the ARTS DN was the impetus or a motive to move to phase 3 renally dedicated trials, starting with Fidelio. So we know that Fidelio is about is a kidney outcome trial. It's about 5,700 patients, 3 phases. The run-in period, which was or allowing the patients to maximally adjust their RAS blockers to the maximum tolerated doses. So nobody was with like enalapril of 5 or losartan of 25. It was all maximally tolerated. Then afterwards, the screening period, which was brief, then the randomization after that, the double blind. So finerenone 10 milligrams if the GFR between 25 to 60, or 20 milligrams right away if the GFR is more than 60. And at the end of the finerenone program, they ended with about 73% of the patients with a 20 milligrams, either from the start or as an increase in the dose from the 10 milligrams. The other group was the placebo. Then after that, we know they have included either moderately increased albuminuria with eGFR of at least 25 and a diabetic retinopathy, or severely increased albuminuria with eGFR between 25 to 75. The median follow-up was 2.6 years, and the recruitment time was between September 2015 and June 2018. I'm mentioning the dates because they are important, and I'll say why in a minute. So a quick look at the baseline characteristics here. So notice the mean GFR is 44. Half of those patients, or over half of those patients, are between 25 to 45. The mean urine ACR is quite high, about 850 milligram per gram, and close to 90% of those in the severely increased albuminuria range. So we are talking about a quite advanced CKD population. We know that almost everyone was on RAS blockers, maximally tolerated, and a very small proportion were on SGLT2 inhibitors, but we all know that the recruitment time was 2015 to 2018, and credence came out in 2019, and probably that's why. Otherwise, probably this number would have been higher. So just to summarize, as I mentioned, this is a cohort with advanced CKD, stage 3 to 4 mostly, close to 90% severely increased albuminuria, everybody was on RAS blockers. Less than 5% were taken SGLT2 inhibitors owing to the trial period. So the primary outcome, we have a risk reduction of 18%, eGFR declined by 40%, kidney failure or renal death. We noticed the curve start to separate, or the effect of finerenone start to take place, I'd say, close to 12 months. It wasn't yearly separation. The secondary composite cardiovascular outcome showed a risk reduction of 14%, which was composite of death from cardiovascular causes, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. So more details. So I have shown you the primary outcome, then the secondary outcome as well. And I have just shown this slide to say that they have included a more strict renal hardened point, which is the 57% decline in the GFR rather than the 40%, which is equivalent to doubling of serum creatinine as a more sensitive surrogate marker for kidney outcomes. And it was actually quite significant, whereas with a risk reduction of about 32%, that is a hazard ratio of 0.68. So very promising results from the Fidelio. So about the eGFR, we know that if you look at the first blue square, which belongs to the finerenone group, there is a drop or acute mild drop in the GFR of like 2.5 ml in comparison to the placebo. But down the road with the long-term follow-up, this translates only to 2.6 in comparison to about 4 ml per minute per year of decline in the placebo group. So they did well with the finerenone on this aspect here. Also, the urine ACR showed very promising or good results. If we look at month 4, we see about 30% reduction in the urine ACR, which was maintained after that in the finerenone group as well. So again, since in these big trials, we talk about efficacy and safety, we want to know how this medication is efficacious. So since there is no difference in the A1C or body weight between finerenone or placebo groups, it's very unlikely to be exerting its effect through a metabolic pathway. And since the reduction in albuminuria occurred quite early, and since there was a modest effect on the systolic BP by a difference that doesn't exceed 3 millimeter mercury, and since there was an early separation of the curves for the key secondary outcomes, it might mean that there is a probable natriuretic or hemodynamic effect. But we know from the mechanism of action of this medication, which was supported by the delayed separation of the curves that start to occur about 12 months, it's mostly acting through a tissue remodeling that usually takes time, / anti-inflammatory or antifibrotic effect. So moving to the safety, we know that hyperkalemia was a side effect that was noticed. However, the hyperkalemia-related medication discontinuation was not that big. It was only 2.3% in finerenone versus 0.9% in placebo. There was no fatal hyperkalemia adverse events that were reported. They have included patients who were less than 4.8 millimole per liter. If the potassium exceeds 5.5, the finerenone to be held and to be resumed once the K goes below 5. So regular monitoring was a key in this trial in terms of potassium levels. So to extend our knowledge about the positive effects of finerenone in a wider CKD population, or let me say less advanced CKD population, we move to talk about the Figuro trial. Very similar design, almost the same design. It's a complementary trial to the Fidelio. Whatever primary endpoint was in Fidelio is going to be the secondary in Figuro and vice versa. So 7,400 patients, the same phases of run-in, screening, and double-blind treatment, the same finerenone placebo 1-to-1 ratio. However, the criteria were moderately increased albuminuria with eGFR of 25 to 90, or severely increased albuminuria with a GFR that exceeds 60. A median follow-up of 3.4 years versus 2.6 in the Fidelio trial. So we know that there is an overlapping population between the two trials in this phase 3 program. So we'll do the same as we did in the Fidelio. So we noticed that the mean GFR is 67 versus 44 in Fidelio. More than 60% of the patients had a GFR of more than 60, median urine ACR of 300 in comparison to 850 in Fidelio. More than half of these patients had a severely increased albuminuria in comparison to 87% in Fidelio. Everybody was on RAS blockers, and again, for the same reason, SGLT2 inhibitors close to 8.5%. So to summarize, less advanced CKD population. And when I say more than 60% of the patients had a GFR of at least 60, you would imagine here the importance of knowing the other component of the DKD diagnosis, which is the urine ACR. So I'm highlighting the importance of early CKD screen, the appropriate screen. So this is the primary outcome, reduction of 13% for the primary CVD outcome, the same parameters we have talked about. And you could see the separation of the curve that started close to 6 months. Talking about the composite kidney outcome, here it just missed being statistically significant with a risk reduction of 13%. However, when they did the more sensitive surrogate marker, which is the 57% that is equivalent to the doubling of the serum creatinine, the risk reduction was 23%, and it was statistically significant as well. Okay, so more details about the efficacy outcomes. So the primary outcome, as we mentioned, 13% risk reduction, was clearly led by the hospitalization for heart failure. The 40%, as I mentioned, kidney composite outcome was just missed being significant from statistical standpoint. However, the 57 has made it clearly. So combining both to be in the Fidelity meta-analysis, the key question here was, does finerenone added to the maximally tolerated RAS blockers reduce CVD and kidney disease progression over a broad range of CKD patients with type 2 diabetes? So we know that they are both complementary trials. The difference in Fidelity, we have more patients. We have more than 13,000 patients. They concentrated on the cardiovascular outcomes and the kidney outcomes. But again, they concentrated on a more strict, hard endpoint, which is the 57 decline in eGFR, in addition to renal death. So looking at the results, 23% risk reduction. That is statistically significant, quite significant actually. Looking at the components, the very good news that I want to highlight here, we have a 20% risk in 20% risk reduction in dialysis or end-stage kidney disease, which is defined as basically the kidney failure, which is defined as ESKD, that is dialysis more than 90 days or transplant. So basically renal replacement therapy. So no matter your GFR category or urine ACR, the benefit was extended to all the categories of either eGFR or urine ACR. Okay, in terms of the composite cardiovascular outcome, there was a 14% risk reduction, quite early separation of the curve. It was led by the hospitalization for heart failure. So again, it was a very good risk reduction value of 22%. That is quite significant. Okay, so an important question that we all ask probably, what about the combination use of SGLT2 inhibitors with finerenone? So we know each one of these medications would act differently through a certain mechanism. So in a preclinical model, this is hypertension. It's not a diabetes study. However, they compared placebo versus empagliflozin versus finerenone versus a low-dose combination on a multiple cardiorenal parameters. And the best result was actually for the low-dose combination that showed the best survival on the right-sided figure. The top number here, about a 93% survival for the low-dose combination, and the least amount of fibrosis that we could appreciate on the left-sided figure, either cardiac or renal fibrosis. So from preclinically moving to the clinical ground, we know that the SGLT2 inhibitors were only 6.7% in the Fidelity analysis. So this was done based on SGLT2 inhibitors in the Fidelity analysis. It was 877 patients. So looking at the cardiovascular composite outcome, you can see that the hazard ratio is less with SGLT2 inhibitors. However, it missed being significant with the p-value for interaction. The kidney composite outcome, again, it showed a trend towards a better result with SGLT2 inhibitors with finerenone with a hazard ratio of 0.42 versus 0.8, but again, the p-value was 0.29. This was the analysis at baseline, and also they did an analysis while the patients were on treatment. Results were similar. However, the hospitalization for heart failure, again, is leading the results here with a very impressive risk reduction and hazard ratio of 0.18 whenever there is SGLT2 inhibitors, with a p-value that is quite significant. So what I want to mention at the bottom line, that finerenone exerted a cardiorenal benefit, and it was observed irrespective of the SGLT2 inhibitor use. There was a trend towards better outcomes whenever there is SGLT2 inhibitors. However, the benefit was there either way. So this is another point to mention regarding the safety, regarding the potassium. This is a multivariate analysis of time to event or time to potassium more than 5.5. This is from Fidelio. And I brought up this point here to mention that the lowest risk for hyperkalemia was whenever SGLT2 inhibitor was used on top of the finerenone. And even you can notice the SGLT2 inhibitor risk is lower than the diuretic risk. So what I want to say here, SGLT2 inhibitor plus finerenone had a lower risk for hyperkalemia whenever there is finerenone plus any other diuretic. And we know that the SGLT2 inhibitors has a trend towards improving the distal delivery of potassium. So probably this is one of the mechanisms to see such result. And it's quite encouraging because we know when we have RAS blocker or ACE or ARB or finerenone, that is giving me a trend of higher potassium. Using SGLT2 inhibitor in that regard could be a way to mitigate this risk. One of the trials that are ongoing, the confidence trial, which test basically whether dual therapy with finerenone and empagliflozin is superior to either agent alone in reducing albuminuria. This is still ongoing, and I'd say it's expected to be released in late 2024, if I'm not mistaken, and it's one of the highly awaited trials. And it's amongst other trials that are ongoing. So such as in SGLT2 inhibitors, when we talk about credence in diabetic kidney disease and DAPA-CKD in the non-diabetic kidney disease, we have another trial here that's called FIND-CKD to test the effect of finerenone on the slope of eGFR in non-diabetic CKD population, expected to be released in 2025. And the trials of finerenone on heart failure are also ongoing. There are multiple of them, but the most awaited one is the FINE-ARTS heart failure and HFpEF population that is expected to be released hopefully later this year. So within the scope of finerenone, these are the trials that we have mentioned. I'd say in the green color, they confirmed cardiorenal benefits, either the phase 2 trials or the phase 3 studies. The trials that I'd say being confirmed are other ones, such as the confidence that I mentioned, or the FINE-ARTS heart failure, or even in the diabetic population, such as the Fiona. So given all these promising results, we had a consensus from the ADA, KDIGO, about the holistic approach to diabetic kidney disease. We know that metformin and SGLT2 inhibitors are already included, and as well as the non-steroidal MRAs, as long as the inclusion criteria are there. So once the GFR is above 25, the ACR is above 30 milligram per gram, the potassium is less than 4.8, all these stipulations are there. It's already included in the type 2 diabetes algorithm or approach. So zooming out or taking a wider look, long time ago, we had no therapies for diabetic kidney disease. The rate of annual GFR loss, you can see that it was about 10 to 12 ml per minute. That got improved afterwards to about 5 to 6 ml per minute when we had our RAS blockers emerged in early 2000s. And this improved further when we had our SGLT2 inhibitors starting in 2019 down to 2 to 2.5 ml per minute on annual loss. And luckily now with finerenone, it's even down to 1 to 1.5 ml per minute. That is not the normal, which is 0.8 as a result of the normal aging process. But hopefully we are approaching that with all these promising therapies. So the pillars or the cornerstone treatments of diabetic kidney disease, I can't stress enough the importance of risk factor management as the first line to go with always, by healthy lifestyle modifications, controlling blood pressure and blood sugar, moving through the RAS blockers, ACE and R, then the SGLT2 inhibitors, as well as the MRAs. And we all know about the GLP-1 agonist as well in the FLOW trial. That could be the next pillar or cornerstone of treatment to be added as well. So I think at the end, I want to say that the comprehensive care, as I have mentioned, is the most important approach to diabetic kidney disease management. My take-home points today are patients with diabetes should be routinely screened for DKD with assessments of both urine ACR and eGFR following the current guidelines. The historical standard of care for treating DKD that are glycemic control, BP control, RAS blockade remains an integral part in the cardiorenal protection despite the recent advances. SGLT2 inhibitors provide amazing and good results, but we know that there is a residual risk of CKD progression that remains, highlighting the importance of adding newer therapies. That is the non-steroidal MRAs that we have talked about today. And we know that combining both modalities, SGLT2 inhibitor and non-steroidal MRAs, is currently being investigated and hopefully will await results in the near future about that aspect. Thank you, and I'm happy to take any questions or comments.
Thank you, Dr. Mohanad, for this excellent talk about diabetic kidney disease. And it was an excellent journey starting from diagnosis, going through the updates and the management. I would encourage our audience at this point to add their question to the Q&A panel if they have, and they can start a question from the audience. I think we will start by going through the diagnosis. What's like your role or the role of the urine albumin curate ratio for the guiding the management of the treatment? So is it the only one, or use other like parameters to guide the management?
I'd say it's a holistic approach. It's not only there in ACR. We'll look at the patient clinically, of course, and then we'll combine both eGFR and urine ACR to categorize our patient and know his CKD stage and talk about his risks after that in the future. So it's only one parameter amongst other ones.
Right. And another question.
Excuse me, Dr.
Yes.
Dr. Mohanad, can you turn on your camera?
Okay, sure.
Thank
you. We have a question from Gino in the audience. How often should eGFR and ACR be measured in people with DKD? I think you explained, Dr. Mohanad, about that we are underutilizing or doing the optimal practice. So how often would do that?
So I'd say if the GFR is less than 60 and their ACR is more than 30, to do it at least twice a year. And
this is in type 1 and type 2 will do it from the time
this is
from the person. Yes.
Yes.
Sorry. So is it the same for type 1 and type 2?
No, so for type 2, you start whenever the patient gets diagnosed, because usually type 2 gets to us late. They could be having diabetes for quite a number of years before we see them. However, type 1, you could wait for a number of years to start screening them after that.
In the same line of diagnosis, there's a question in the chat that do we need to have a diabetic retinopathy to start the management of DKD, or we don't need to have this clinical sign to initiate the treatment?
Well, I'd say usually retinopathy would precede the nephropathy in the classical example, but whenever there is an indication to treat from renal standpoint based on our clinical and biochemical parameters, I would just go ahead and treat.
Now I think we have more question about the management. So the always asked or the most commonly asked questions about when to use both. If we have a new patient who's novel to both the SGLT2 and finerenone, so which one to start, which one to choose, and do you can combine them together at the beginning, or you will leave like a gap time between them?
I wouldn't start them simultaneously. I would do that sequentially. If I start with SGLT2 inhibitors, for example, I'd wait at least 4 weeks before I introduce finerenone, just because I want to know if there was an effect with the SGLT2 inhibitors. It's not wrong to start with finerenone without SGLT2 inhibitor. It was not like an inclusion criteria or like an important stipulation to have when the Fidelio or Figuro happened. So you could do either way, but I'd say in the guidelines, they have the SGLT2 inhibitors as a first line. So I would probably start with that / the metformin, like for diabetes and in general. Then I would add finerenone as long as the potassium is okay, the GFR is more than 25, and the urine ACR is more than 30.
Thank you. There's a question from Ali in the audience that is there a difference in the effectiveness of Finenon between the different doses, 10 milligram and 20 milligram?
I didn't see that there was an exact sentence mentioning that it's a dose dependent, but as I mentioned during the talk today, about 73% of the patients, like 3/4 of them, ended up being on the 20 milligrams. But I'm not quite sure if there is a dose dependent effect here.
And another question about Finenon in relation to EGFR. So you will continue to use Finenon until which level of EGFR, and if patient is initiated in dialysis, you would continue that or you would stop?
So I just take the question for an extra step. For the SGLT2 inhibitors, would continue the patients until they are reach the dialysis point. Even there are studies now testing the SGLT2s on dialysis patients. However, in the finerenone, I would just play it safely for now and go by the guidelines. Probably not less than 15. I wouldn't go below that, and I wouldn't take it to the dialysis point, especially for the potassium issue for the time being.
Excellent. I think there's another question about at which patient you would prefer to use the old mineralocorticoid receptor antagonist versus the non-steroidal. Is there a specific population, or you would use them in all patients?
So this is about steroidal versus non-steroidal, you mean?
Yes. Yes.
Yeah. So for the steroidal MRAs, they are quite old. We have very important trials for the spironolactone like rails, or for the eplerenone like the emphasis for the emphasis for the heart failure in 2003 and 2011. So if it's for heart failure or resistant hypertension, I would concentrate on the original or traditional steroidal MRAs. If we are talking about kidney specific benefits, here we'll talk about the non-steroidal, which is finerenone, because it showed much better evidence actually.
Another question is about can we use finerenone as prophylaxis? For example, the patient did not start to show proteinuria or albuminuria, and we know the patient is diabetic, maybe controlled with other medication. Would you consider using it or not?
I would not, probably, because the trial told us that it's urine ACR of at least 30. So if there is no albuminuria, I wouldn't use finerenone per se.
I think we have a lot of questions, so if you can bear with me, I'm trying to go through them. There's a question about the diagnosis. So would you depend on the ACR for screening of type 2 diabetes, or would you use 24-hour urine collection? Or let's rephrase the question, in which patient of type 2 diabetes you would consider doing 24-hour as a diagnosis tool?
I think the guidelines mentioned that we can do the urine ACR as a spot sample. So if I don't need to, because doing a 24 hours is always not easy to the patient. So if we don't need to go down that route, I wouldn't do so. So I'm just going to do the spot sample beside the EGFR, of course.
Great. So there's a question, it's a long question. I'm trying to go through it. So will this use of non-steroidal MRA is dependent on the level of sugar control, or it has independent effect on kidney disease progression, like efficacy is directly with glycemic control or not?
It didn't exert its effect through metabolic pathways. We saw that there was no evidence or no difference between finerenone versus placebo on the hemoglobin A1C. So its effect was irrespective of any control. It's the same with SGLT2 inhibitors. Their effect was irrespective of the glycemic control. So it's not.
Would you consider finerenone in proteinuric patient other than diabetes? Also, this will include type 1 diabetes. For example, like IgA or FSGS or type 1.
So hopefully the FIND CKD trial will let us know about that, which is testing the effect of finerenone in the non-diabetic CKD. So it's interesting in terms of type 1 because there is I think I went through a study that was like an animal model talking about type 1. I can't recall how significant it was, but there was a trend toward benefit. But so far, we don't have any clinical studies about type 1 diabetes.
So there's a question about patient with heart failure. Would you combine finerenone with, for example, spironolactone for patient with heart failure?
Well, finerenone for heart failure outcomes, actually, there is very promising data. So there was an analysis that was done, I think, by Dr. Bakris, tested multiple heart failure endpoints like the time to first heart failure hospitalization or the composite of cardiovascular death plus heart failure hospitalization or time to recurrent heart failure hospitalization or the composite between the hospitalization and the recurrent heart failure. And it was all, whenever you are on finerenone, all in favor to have lower number of events. So there is promising data, but again, the big trials like the Fine Arts HF, we are still waiting for these results. In terms of combining both, I wouldn't do that for the time being, honestly, especially with the hyperkalemia risk. So no, I wouldn't combine them. And I would wait for the big trials to tell us in the near future.
There's a question from, I think, Fatima. How often the guidelines get updated? I think this is a general question, and I'm not sure she's referring to like local or international guideline for the management. But I think all of the guidelines has been recently updated, especially that we got SGL2 and finerenone introduced, like many medication in the field of nephrology got introduced. So we were lucky to have those medication coming on board. If you agree, Dr. Mahlet.
Yes, definitely. I agree with you. Lots of advances in the recent time. So multiple updates were added to the guidelines for diabetes.
There's another question. Is there any specific situation where you would not use finerenone other than hyperkalemia, or if there is a known-like interaction with certain medication?
I'm not aware of any specific interaction with any medication when I went through the literature. I think the most concerning points for the people was the elevated potassium. But if you look at the literature, when you see the dual RAS blocker trials, like the Altitude or the VA Nephron or the On Target, they all had like hyperkalemia risk that were like quite higher in comparison to the Fidelio and Figuro and the Fidelity. If you consider finerenone is the distal end of the RAS system, it's another RAS blocker if you would consider that. And if you would see these trials adding finerenone on top of RAS blockers and having dual RAS blocker here, I think this is a very acceptable risk of elevated potassium. I mean, that is what I'm referring to here is the hyperkalemia related to medication discontinuation was like very accepted. So I think aside from the potassium, there is nothing else that we would be concerned about.
Excellent. There's a question I think you explained about the progress and the effect that we have with different interventions. So the question from Enigma, do patients end up to dialysis if the therapy is not effective? So I think it's about like the prognosis or progress if patient is on finerenone. How slow is the progression of CKD?
Yes, so finerenone just added to the other therapies. So we said without any CKD therapy, the risk of annual GFR loss was about like 10 to 12 ml per minute. And adding RAS blockers, then SGLT2 inhibitors, then finerenone, we have reached, thankfully, to close to like 1.5 to 2 ml per minute as an annual loss. So that's gives patients quite number of years ahead of being on dialysis or renal replacement therapy.
Another question from, I think, Ala or Ala, I'm not sure. So it's in English. So in Fidelio, only patients with urine albumin more than 30 milligram were included, and only patient with urine albumin more than 300 milligram showed benefit. Any other study showed that there is a benefit between 30 and 300?
Yes, this is we're talking about the Figuro here. So the Fidelio was about the more advanced, and the Figuro showed us the benefit in the less advanced population.
Apology to our colleagues. There's some general questions, so I'm trying to focus about the talk tonight, and if we have time, we might consider the other question. There's a question: is this spironolactone a steroidal MRA?
Yes, it is a steroidal MRA.
Like it was explained in one of your slides, Dr. Mohammed.
So the spironolactone was one of the oldest steroidal MRAs. I believe it goes back to the 1960s. And I think it's different from the non-steroidal MRAs, from multiple aspects, but it has well-proven effects in heart failure populations and in resistant hypertension as a fourth line medication. Hopefully I answered the question there.
Thank you, Dr. Mohammed. Okay, so I think also this one was answered. I'm not sure, what would, yes, Dr.
I think almost we are approaching. We have 1 minute more though.
Yes, so I'm just trying to find a question. I think most of the question we have gone through them and we answered in one way or another. So with this, I would like to thank you, Dr. Mohammed, for your nice presentation. I would like to thank the audience for their attendance and for their interaction. I would like also to thank the Saudi Society of Nephrology, and thank you.
Thank you
so very much.
Thanks,
Dr. Mohammed and Dr. Khalid, for wonderful educational sessions. Actually, I would like to disclose the attendees is almost 4,800. And we have so many questions, more than 200 questions came in Q&A. So thanks you very much, Khalid, for managing this. So see you, inshallah, next time. So on Saturday, we'll have another educational events and webinar. It will talk about the ANCA-associated vasculitis. Before we are leaving today, we'd like also not to forget to thank the Bayer company for sponsoring this educational event, and we'd like to thank them as always. They are with the society and sponsoring educational events. See you on Saturday inshallah. تصبحون على خير ومع السلامة.
سلام.
مع السلامة خالد.